And then we're going to have some questions and answers at the end. I also have, well, never mind that. Okay, we'll just go ahead. So, put that on. Oh, I do have two things to say at the beginning. One, whoever said that they looked up a doctor's name and the person was going to a veterinarian, I actually am still boarded as a veterinary technician. So when you see me, you're not even seeing the veterinarian, you just see the veterinary technician. So,
Gotta be careful, right?
and then, okay. I could start with a Beethoven joke, but you just got a whole bunch of good jokes from that other guy. So, overview: mood, depression, apathy, anxiety and panic attacks, and then dementia, hallucinations, and psychosis. Go ahead. So this is kind of hard to read. Basically, in the middle, right there, that is considered time 0. That's the time of diagnosis. This chart looks at 20 years before that, 20 years after that. And it's basically all these little itty-bitty words are different symptoms of Parkinson's. Things start way back 20 years before, like constipation, sleep changes, and one of those changes is depression. So right here, people don't even have symptoms of depression yet, symptoms of Parkinson's yet, but they got depression. So all the people that say, oh, depression is just because you got the illness, it starts way before. It can, or it can start after. Over the years, some of these symptoms, like dementia, urinary symptoms, pain, the non-motor symptoms, they worsen. Right here, the motor symptoms start, and they worsen over time. And as you get to the end, dementia, cognitive problems can happen, and that can end up in psychosis. So we're going to discuss a little bit of those mood and cognitive problems. Go ahead. So depression, 40 to 60%, about half of people with Parkinson's have depression. Some of those people, it's a major depression, and by definition, major depression is 2 weeks, just 2 weeks, most of the time, having the top two symptoms, depressed mood and loss of interest or pleasure. Then they also have some of the other symptoms. Sleep or appetite changes, either eating too much or too little, sleeping too much or too little, could be either way, decreased concentration, increased fatigue, slowing down, feeling restless, feeling worthless or guilty, and sometimes, but probably not very common, but sometimes it can even be suicidal ideations or wishing for death. The rest of people just have a minor depression. It's still enough to affect quality of life, affect the caregiver's quality of life, and so it needs to be addressed. Go ahead. Should I actually sit down so you guys can see better? Or? Yeah, okay, so you can see better. Yeah, it's good to have the mic. Okay, so depression usually occurs either earlier, around the time of diagnosis, or even before, or later. And some people have said, the early part, well, that's just a reaction to getting the diagnosis. But like we said, it can happen well before you get diagnosed. It really is intrinsic to Parkinson's. What I mean by that, the same changes that cause your motor symptoms, they also affect other parts of the brain that affect your mood. It's some of the same regions, deep down inside, the basal ganglia, the frontal lobes. It's also some of the same neurotransmitters or neurochemicals. So dopamine, serotonin, and norepinephrine. Another thing that can prove that it's intrinsic to the disease, you can have two separate people with the same level of function, like the same level of deficits or the same amount of tremors or whatever, and yet one of them has a very different mood from the other one. So it's intrinsic to the disease. Go ahead. One thing you always have to ask with depression is it really depression? Is it something else? For instance, depression is something where they have all the symptoms listed before, but they actually have a feeling of sadness that goes along with it. They're aware of it, and they have that emotional feeling. Very closely related is apathy. And with apathy, they don't feel sad, they just feel neutral. We'll talk about apathy again in a minute. Then the Parkinson's itself has slowness and fatigue with it. And people that are slow and fatigued look depressed, but they might not feel it at all. The other thing is the masked face of Parkinson's. People don't have the expression that they used to have. So they may think that they're smiling and showing their mood and being in a good mood, and you may not see it at all. So it can totally be misinterpreted. So level of emotions in Parkinson's, sometimes people get too little, and sometimes they get too much. So the too little emotion goes back to apathy. For instance, people will be less socially involved, they don't talk much, they're just not interested in doing things, and that we give that the name apathy. It has to do with whether they're motivated to do something or not. And that's caused more by when the frontal lobes of the brain are affected, or it can be. The other end of the extreme is where people have too much emotion, where somebody that used to be kind of normal emotion-wise, all of a sudden they see a patriotic commercial on TV, and instead of just feeling a little bit of warm fuzzy, they feel like they actually start crying. So some people will have that, and they give that a special name too. It's pseudobulbar affect. Big word. In essence, for that one, there is a new medication that's supposed to be designed for that. I think it's already out. It may not be. No, that's the one that Dr. Schrecker talked about last night. It's not out yet, but should be out this year. It got FDA approved yesterday, I think. So next thing is anxiety, and we'll talk about some treatments in just a minute. Anxiety affects 40% of people with Parkinson's, so that's almost half. It can be short-term things, just certain situations. It can be chronic all the time, and it can be very disabling at times. So go ahead, next one. There's 4 main types of diagnosable anxiety that I'm going to go over right now. One is generalized anxiety. That's where all the time people have an increased sense of nervousness. They worry in excess from what you think they should, and it bothers their ability to do things. They may feel physical symptoms with the anxiety, feeling like they have butterflies in their stomach, or racing heart, trouble breathing or swallowing can be a big one, sweating, and increased tremors. So sometimes this is more of a low-grade all-the-time thing, in which case we would consider it the generalized anxiety. And sometimes it comes on in almost sudden attacks, which are typically more sudden onset and more severe. And we'd actually call that a panic attack or an anxiety attack. Those can cause a person very severe physical and emotional distress when they happen. They usually last just a few minutes, but sometimes they can last an hour or more. Go ahead. Oh, you already did it? Good. Okay. So the other 2 kinds, social avoidance. With all this anxiety stuff, people may tend to avoid going to situations like this, going to support groups, going to their exercise classes, because they don't want to be around other people. And what's the worst thing they can do? Be socially isolated. So you got to think about things. Is it because, are they embarrassed by their tremor? Usually, like all of you would probably say, oh, I don't notice so-and-so's tremor. I just look right past it. But yet the person that has it can be very intensely aware of it, and they don't want to go out and do anything because of it. Also, it could be inability to function. For instance, when people wear off, they freeze and they can't move, so they never know, well, in the middle of the support group, when we get up to go to break, am I going to be able to walk, or am I going to be stuck here? The last kind of anxiety is obsessive compulsive disorder, and that refers to thinking certain thoughts over and over again that again are out of control and out of the amount, more than they should be. And so that can affect things. Anxiety, again, it can be associated with the motor fluctuations, meaning when your medication's working, things go well. When the medication wears off, you get symptoms that are physical symptoms, plus some people have maybe not so many physical symptoms, but they can have severe anxiety when they wear off. And transitioning from on to off can be another one. So treating that is a simple way to improve quality of life. The next thing that you can use to treat is mood medications. First of all, the Parkinson medications need to be maximized to prevent these ons and offs, ups and downs all day. And that's without even adding anything new. It's just maybe smaller doses more often. The next thing is considering whether or not to add a medication. So antidepressants are often good for anxiety at lower doses and depression at higher doses. They can do both, some of them, especially the new ones. There's also anti-anxiety medications. Anybody heard of Xanax, Valium? Those are some. They're not the greatest to use. You have to use caution because they can also affect cognition, contributing to confusion, or balance issues. And they're not, in some senses, they're not the best used long term, but yet in some ways they do work better long term. So you have to kind of take those with a grain of salt. One of the better ways to treat these mood disorders is with exercise. Absolutely, exercise helps to reduce anxiety and depression. Counseling and support groups were mentioned earlier today. RTMS is what the picture in the corner shows. It's a new thing. It's actually, there's 3 places in Tucson that do it. I'm sure there's places in Phoenix and elsewhere around the state. They put a magnet over an area of your brain and they treat you. They turn it on and it goes for like 27 and a half minutes or something. And you do a treatment every day for like 10 days. And it can improve mood, depression in particular, for up to 6 months. So that's a new alternative. An older one is electroconvulsive therapy. It is very effective, but it's something that not many people, well, we associate it with the movies in the past where it was shown in a very negative light. But it's still very effective and can be used. Things like bright light, making sure to get plenty of daylight every day can really help mood. If people just stay inside, don't get the daylight, it worsens things. Relaxation, massage in the back, acupuncture, aromatherapy, meditation, music therapy. Any of these supplemental things, they may not work for everybody, they probably won't, but some people will feel better with them. So as long as anything supplemental, whether it's a type of treatment or a type of medication like an actual pill, an oral thing, if it's not something that's gonna break the bank and be too expensive, and it's gonna be safe and go with your other medications, you can give it a try and see if it works for you. And if not, say, okay, it didn't work for me, but it might work for the next person. Okay, so why treat mood? Depression is the #1 thing that negatively influences quality of life. Also, treatment of depression and anxiety make other symptoms much more manageable for both the person with Parkinson's and the caregiver. Next thing, we're going to talk about cognitive, just a few slides too. When you look at the symptoms of Parkinson's disease, the first 5 years or so are considered the honeymoon phase. You're having motor symptoms, but the medications work well. You don't have any of those ons and offs. Then you start getting to a phase where you do have ons and offs, and if you get a little too much medication, you get dyskinesia, a little fidgeting. Then you come to levodopa resistant symptoms, and way down the road, 15, 20 years, that's when the cognitive impairment happens. Go ahead. There are things that are common with aging, and people always ask, well, what's aging and what's the Parkinson's? One of them that commonly occurs with aging is inability to pay attention or concentrate. Another one is that your thinking slows down. You have a delayed response to things, and then slower recall, where it takes more hints to recall things. So those are normal aging. Probably 15% of people, 70 to 90 years old, complain of those types of things. However, in the Parkinson population, it's more like 25% at the time of diagnosis. When you look at Parkinson people 15 to 20 years out, 80% of them at that point will complain of memory issues, and half those will be dementia at that point. Go ahead. Oh, that slide said it's not Alzheimer's dementia. That's a huge point. It's not the same thing as Alzheimer's dementia. So this slide just to show, in normal aging, people have a little bit of decline, but with Parkinson's, at some point, the curve starts worsening faster. You get more decline than the other people your age. And at first, we just call it mild cognitive impairment. It's not to the point of dementia yet. It's just mild, and you can deal with it. You can still be independent. But at some point, it starts progressing faster and causes more problems. That's when we call it dementia. Dementia is the huge umbrella category. Of the dementias, Alzheimer's is 2/3 of it. Everybody else has a different kind of dementia. So Parkinson's dementia falls in that other third. These are the main cognitive symptoms seen in Parkinson's disease, and the first 4 of them probably are the same thing you see in aging. Hard to pay attention, you're slower thinking and responding, it's hard to do problem solving, and memory deficits. Like it's harder for a Parkinson patient to hear something and organize it and store it so that they can easily find it later. The problem-solving executive functions, doctors talk about executive functions a lot, but it doesn't really mean much to you unless you think of what does an executive of a company do? They organize, they plan, they get everything squared away. That's part of the cognitive we're talking about. Language abnormalities, the most common is tip of the tongue. You get to the middle of a sentence, you can't remember the word you want. You forget it. Or you forget your whole train of thought when you're trying to come up with that one little word you want. Visual spatial difficulties are like if you're gonna arrange your living room or something. I think of it more in driving, knowing how fast is that person coming, how much time do I need to get out in traffic. So that's affected in Parkinson's. And then there is neuropsychological testing available where you can see where am I at, and they look at all these different types of memory, and they can say, this is consistent with normal aging, this is perhaps headed towards Parkinson's dementia, yes or no, this is consistent with Alzheimer's dementia. If somebody has depression that's bad enough, they won't be able to pay attention, they won't be able to concentrate, they won't be able to remember. They will look like they have dementia. So they even give it a name, pseudo-dementia. So depression has to be ruled out before you go testing somebody's memory and giving them a diagnosis of dementia. Cognitive treatment. Green Valley, is there anybody? Yeah, Green Valley Support Group. No, you're Sierra Vista. Do we have anybody from Green Valley here? Yeah, there you are, okay. Oh, there, sorry, hi. So they have this saying about give Parkinson's the sack, and it's excellent. Mentally stimulated, physically active, socially connected. 3 biggest things that you can do to keep your cognition going well. Common sense, a nutritious diet, plenty of adequate restful sleep, minimize stress, emphasize joy, emphasize what you can do, not what you can't do, so positive attitude. And then after all that, you think about medications. For the Parkinson medications, at this point when cognitive starts bothering, there's a lot of medications that will exacerbate it. We can clean up your list and get rid of those. And that helps your brain to work better again. Then there's some medications specifically for it. I think they're gonna be in another slide too, so. Yeah, they'll come back again later. Those, so psychosis. Oftentimes when people have dementia going on, they will also get psychosis. This can refer to hallucinations, where you see somebody that's not, like see something that's not there. See a person that's always in the corner of the room. It can be illusions, where you see a garden hose or this little strip on the floor, and you think it's a snake. So it's seeing something that turns into something else. It can be delusions, where you have false beliefs, thinking that somebody's trying to harm you, or that your spouse is an intruder, or something along those lines. And paranoia, because of those delusions especially, you can get paranoia. Usually, the first time that somebody has hallucinations can be, well, I don't know if it's usually, but a lot of times it'll be long before dementia. It's like, that's kind of coming down the road, but not yet. And somebody will have a new medication that doesn't sit well with them. They get a urinary tract infection, or they get dehydrated. Those are 3 big things that cause a person to have their first hallucination. So if somebody's got their first ever time, you look for something else causing it. Later on, they can actually have hallucinations anytime, day or night, not just related to whatever change in their system they had before. And they're more complex. Instead of being just a simple visual thing, it includes all the other senses as well. So again, causes, new meds they don't tolerate anymore, infections and dehydration. Parkinson's, as it progresses, the more closer you are to getting dementia, the more likely you are to have psychosis also. So first of all, again, we just address those exacerbating factors, treat the infections, etc. And then we simplify the Parkinson medications. It's actually a whole list of medications. In general, when you can tolerate all these medications, the current training or thinking in movement disorder circles is to use what we call rational polypharmacy. That's using a cocktail, using a little bit of this, a little bit of that, a little bit of the next thing, and that way you don't have to rely on just one medicine and push it up to side effects. So that's what we do all along, but when those medicines start causing problems, you turn around and switch direction and get rid of them. Also decreasing levodopa sometimes. Sometimes you've gotten rid of all those other things, you have to decrease levodopa. There are the cognitive medications. Aricept and Exelon, actually, I've had a lot of patients where they're starting to have hallucinations, and you start them on those medications are actually to maintain cognitive function where you're at. That's what they're FDA approved for, is to not improve memory, but just maintain where you're at. But oftentimes they can help cut back hallucinations. If somebody has visual hallucinations and they're using those medicines for memory, they'll often get a better response than if they don't. You can also use antipsychotics, but again, that's a much stronger category of medication. It's got side effects of its own. I just had another thought, I forgot what it was. Yeah, I had my last birthday this year, so I'm 49 from now on, okay? What is it? There was something I was supposed to mention to you guys. We talked about it yesterday. Well, it was about, I'll think of it, I'll come back to it. Okay, go on. Oh, that's the end. So I know one of the things was about dyskinesias and tremors. For instance, when people get, same with hallucinations. Dyskinesias, tremors, hallucinations. When do you really need to treat? If you got a little bit of dyskinesia, do you really need to go adjust everything and throw the balance off? There's a lot of thinking that says that once you get dyskinesias, they're just going to get worse, so you got to do something about it now. Same thing with hallucinations. Once they start, they're just going to get worse, so you got to do something. But, for instance, with the psychotics, is it really worth adding a medication like that? Who are you treating? Is it the care partner that's worried about it, the family that's worried about it, or do those things really bother the patient? With dyskinesia and tremor, a lot of times I'll have a couple come in and the care partner says, there's a little bit of tremor in the pinky, we need to treat that, we need to treat that. And yet, oftentimes we can treat the slowness and the stiffness, but tremors up here, and you'd have to use a lot more medication if you even could control it. We don't, sometimes you just can't control it all. And so is it really worth it? When people are dyskinetic, oftentimes it doesn't bother them a bit because they can move. They're so happy to not be frozen solid that they don't mind the dyskinesia. And many times the brain just doesn't even register it. It's like it can be unaware of it. So whenever you're looking at those three things, the dyskinesias, the tremors, the hallucinations, there's times when you might want to treat it and times when you might want to just step back and let it go for now. So, what else is on the list? Medical massage is one thing that we mentioned. Your doctor can give you a script for medical massage. The insurance often doesn't pay for it, but at least that way you can count it on the end of the year expenses for medical expenses, and that helps rack up the amount you need to actually take it off. Okay. I have one other topic, but any questions first? Yes.
Does this have anything to do with acting out dreams, or is that a separate issue?
Excellent question. The question is, does this have anything to do with acting out of dreams? When somebody's asleep and they're acting out their dreams, that's got a specific name. It's REM, sleep disorder. I'll talk about it in a minute. When they wake up from that, sometimes there's some graying of, when am I asleep, when am I awake? So they might have some confusion when they first wake up. That has some significance to have hallucinations at that point, but it's very different from middle of the day being wide awake and having hallucinations. So very different thing. The actual dreaming itself, all of us, even though we don't remember them, are supposedly dreamers at some point. It's usually in the later hours of the night, 4 to 6 a.m., something like that. And when we dream, only our eyeballs are supposed to move. And that's why they call it rapid eye movement sleep, so REM sleep. The eyeballs move, you can see it jiggling under the lids. Everything else should be paralyzed. But sometimes the brain loses the off switch. You lose that paralysis, so if somebody's dreaming of running, fighting, they will actually be hitting out, yelling, kicking, whatever. That's something that's usually more bothersome to the bed partner, wakes the bed partner up. Often the person with Parkinson's doesn't remember it a bit. So do you need to treat it there? Maybe earplugs in the line of pillows, When it becomes a problem is if that person's sleep is also disrupted, and particularly in the rare cases where somebody will actually throw themselves out of bed and get hurt repeatedly, or even get up and start sleepwalking out the road, out the door or something. Those are times when it definitely needs to be treated. Does that answer your question? Okay. Yes, another question.
Have you been involved with or are following anything about the connection of the microbiome and the brain connection, the gut to brain?
So the question is about whether or not I'm following the connection between the brain and the microbiome, and you're referring to the gut microbiome? So yeah, there's some interesting things coming out. I don't know everything about it, but there's some interesting things coming out about the bacteria in our gut. We have good bacteria and bad bacteria. And that's kind of the thinking behind the probiotics, is to get the good bacteria back in there. There have been studies that link having the wrong bacteria in your gut to depression and to some of these other things. So I don't know, I've read a little bit about where you might go, like under a doctor's instruction, they might have you take antibiotics and kind of kill off all the bacteria, and then use probiotics and or stool,
Fecal matter implants.
fecal implants, yeah, to get your correct bacteria back again. So.
We can go to England for that.
Oh, the comment is that you can go to England to get that done. Yeah. Other questions? Yes.
Are you aware of any studies where they're suggesting that all treatment per the usual and customary prescription does not work, where they're actually adjusting and making treatment as far as the prescription of medications more personalized to the individual versus just a blanket of take this pill 3 times a day?
So the question has to do with personalization of medication, basically. And that's the big difference between a primary doctor, a general neurologist, and a movement disorder specialist. There's a good dozen medications for Parkinson's, plus a whole bunch of alternative things and extra things. And the difference between those categories of physicians is how many arrows do they have in their quiver? How many tools do they have in their toolbox? How many are they really comfortable with? And so the movement disorder person has all those things at their disposal, and depending on what symptoms you're wanting to treat, what side effects you're having to things, you totally tailor to you. And then also, with the primary care doctors, they might have 5 minutes with you. The movement disorder doctor often has more time with you. And then they can just fine-tune the schedule. Okay, you take your dose at 4 o'clock in the afternoon, but you're wearing off at 3. Let's change or move that dose. And trying to get everything just spot on for you.
suggest that they see a motor specialist, neurologist, because it could be a precursor to Parkinson's?
So the question is, for somebody that's not diagnosed yet, if they get depression, would I recommend that they go to a neurologist to check for Parkinson's? They're actually doing all kinds of studies on which kind of precursors like that actually are more likely to lead to Parkinson's versus not. Constipation and depression are pretty much so widespread that they're not specific enough. So it's if you have a family history or something, you could go check it out, but otherwise it may or may not show anything at that point.
They're being silo treated too. They treat the depression, or they treat the sleep problem.
Okay, so the comment is that they're being silo treated, where they treat the one thing and they don't look at anything else. Just the depression, just the sleep, whatever. So there's a question back there.
I have two. Will aromatherapy work if you don't have a sense of smell?
Oh, good question. Whether aromatherapy will work if you don't have a sense of smell. I have no idea. I have no idea. That's a good one. Did you have another one you said?
Yes, and what is qualifies a massage for as medical?
I don't know an exact answer. Maybe we shouldn't film this part, but if I have a patient with Parkinson's and they're getting massages, to me that's enough, because Parkinson's has rigidity, it's got pain associated. It's just another one of those things another one of those tools that's gonna help. So I'll just write somebody a script. Yeah.
Would you write it for the care partner?
You pushed the button a little bit, but, well, actually, okay, technically, I could not, because I don't have your medical records, I'm not seeing you. So, okay. But it's a good thought. Yeah, get through your primary care doctor. There was another question here? Oh, here.
As far as depression, I keep us very physically, socially active, which is good for both of us. Is there ever a point in depression that you're like forcing it, or should you just always continue to try to do it?
So a question is about when you've got depression, like they always try to stay very socially active. Is that appropriate, or is there a time when you're trying to force it too much and that causes a problem? Good question. Depression and particularly apathy problems, people, they won't take the initiative to go out and do things at all. And so the only way to get them out is to not ask them, what do you want to do today? Certainly not an open-ended question. It's, would you rather go to the ball game or go to the mall? Would you rather eat this or eat that? It's got to be close-end. It gives them some option, but it still gets them active and gets them doing something.
So keep encouraging them.
Yeah, so keep encouraging them to do things.
It is cheaper to go to the ball game.
Oh, it is cheaper to go to the ball game than the mall. Well, okay. I don't know, the hot dogs are pretty expensive nowadays. There's some questions up here.